Audiometric screening. County collaboration. This presentation has been developed in collaboration with the health plans listed to the right, reflecting the collective efforts and contributions of all parties involved. Learning objectives. This training is required for providers and staff performing the screenings or for those teaching others. By the end of the training, participants will be able to understand requirements for equipment and the screening environment, know how to condition, recondition, and screen using play and traditional audiometry, document results of audiometric screening, describe the components and the proper use/care of the audiometer, and identify the different types of hearing loss and how it affects the child. Who needs to be trained? All providers and staff involved in screenings, as well as those responsible for training others. Frequency. The training is required for all new hires and must be repeated every 4 years thereafter. Children shall be assessed for risk at each well visit, starting at birth by reviewing family history, observation for structural defects, behavioral observations such as loss of hearing or speech delay, and by performing a screening test at the appropriate ages with an audiometer. To properly screen for hearing loss and hearing disorders, the American Academy of Pediatrics recommends that all providers reference the Bright Futures periodicity schedule. Visit the American Academy of Pediatrics website at aap.org to access this schedule. It is updated annually. This is a larger view of the Bright Futures hearing screening recommendations according to age. The dot means a screening test is to be performed. The star means risk assessment is to be performed with appropriate action to follow if positive. Based on the Bright Futures periodicity schedule, hearing screening is only performed at 4, 5, 6, 8, and 10 years of age, as indicated with a dot. A hearing risk assessment is done during the other ages indicated with a star. For adolescents, a hearing screening test is to be performed once between 11 and 14 years old, once between 15 to 17 years old, and once between 18 to 21 years old. A hearing risk assessment is done during the other age ranges indicated with a star. If there is a positive result indicated from the hearing risk assessment, a hearing screening test must be performed. Hearing screening should be completed beginning at age 4 years old using a pure tone air conduction audiometer, which is calibrated yearly. Use play audiometry for children under 6 years old, or special needs children and older children who appear to be shy. There are 4 things needed for successful screening. 1. The screener must be qualified to perform the screening. 2. The audiometer must be calibrated by a qualified technician at least annually. 3. The audiometer must be functioning properly. And 4. The screening environment must be in a quiet location. Now, let's take a moment to review the equipment you will need to perform the hearing screening test. Audiometers should be equipped with switches or dials to control the power, ear selector, frequency, intensity, and tone. They should also come with earphones and a power cord. Intensity or volume is measured in decibels or dB. 0 decibel is usually the softest sound that can be heard by a normal hearing person at any pitch or frequency. Decibels are measured on a logarithmic scale. Each increase of 10 on the scale represents a 10-fold increase in loudness. 20 decibels is 10 times as loud as 10 decibels, and 30 decibels is 100 times as loud as 10 decibels, and so on. Normal human conversation is around 60 decibels. A rock concert can average between 110 and 120 decibels. Sound becomes painful at 125 decibels. Frequency refers to the number of sound waves, vibrations occurring per second. It is measured in hertz, or Hz. When conducting the actual hearing screening at 20 decibels, measure each frequency as a separate test at 500, 1000, 2000, and 4000 Hz, with 3000 Hz being optional, and also at 6,000 and 8,000 Hz for patients 11 years and older, because most human speech falls within this range. Individuals who have problems hearing within these frequencies will have difficulty understanding speech and language. We will now cover the 3 important phases of audiometric screening. The first phase is called conditioning. Conditioning is an important phase of a hearing screening to orient the patient to the procedure, how the beep will sound, and what to do when they hear the beep. With earphones still on the table, the conditioning phase is set to 90 decibels at 4,000 Hz. The sound is loud enough to hear while the earphones are still on the table. Ask the patient to listen for the beep. Press the tone for 1 Mississippi and note the patient's response. The second phase is called reconditioning or confirmation. In this next phase, the audiometer is then set to 50 decibels at 4,000 Hz. The earphones should now be placed appropriately over the patient's ears. Remember, the red goes over the right ear. This reconditioning phase confirms that the child can still hear the sound with the earphones on and confirms that they understand the instructions before they can proceed to the screening phase. Ask the patient to listen for the beep, press the tone, and note the patient's response. The third phase is the actual screening phase and is done at 20 decibels. With the audiometer set to the right ear, press the tone and note the patient's response to each frequency. If the child does not respond to any of the frequencies during the actual screening, the patient may simply not have the proper understanding of this procedure, and the screener should return to the reconditioning phase to confirm if the patient understands the instructions. If they respond, proceed to the screening phase and document the results for both ears. If the patient did not respond during the reconditioning phase, the child may be uncooperative and shall be asked to return within 2 to 6 weeks for a rescreening. Play audiometry allows hearing screening of young toddlers and preschoolers by playing a game with the child, while at the same time assessing their hearing. This is usually done at 6 years old and younger. You will need plain blocks and a noise-free basket made of plastic or wicker. Plain, uncolored blocks are preferred so not to distract the child when the screening is performed. Before starting the game, the screener must first introduce the beep or the sound to orient the child to the procedure, also called the conditioning phase. Position the child on your dominant side for screening. Keep earphones on the table during the conditioning phase. Turn on the audiometer and set to the right ear and pulse tone. With the audiometer set at 90 decibels and 4,000 Hz, ask the child to listen to the beep. These settings will make the beep loud enough to hear without putting on the headphones. Press the tone for 1 Mississippi and acknowledge that the child hears the beep. Conditioning Step 2. Demonstrate the game of who gets to put the block in the basket first. 1. The screener and the child each get a block. 2. Place the empty basket in front of the child. 3. Instruct and prompt the child to put the block in the basket when the beep is heard. Screener points to their ear and taps the basket, but do not put the block in the basket first. Conditioning Game 1. Screener wins. 1. Ask the child to listen for the beep. 2. Press the tone for 1 Mississippi. 3. Screener puts the block in the basket first. 4. Child follows after. 5. Screener praises the child. Wonderful! Great job! That was awesome! Conditioning Game 2. Let the child win. 1. The screener and the child each get a block. 2. Screener says, "Let's see how fast you are." 3. Ask the child to listen for the beep. 4. Press the tone for 1 Mississippi. 5. Let the child win. Child puts the block in the basket first. 6. Screener follows after. 7. Screener praises the child. Wonderful. Good job. Awesome. Conditioning game 3. Child plays alone. 1. Give the child a block. Screener does not get a block. 2. Ask the child to listen for the beep. 3. Press the tone for 1 Mississippi. 4. Child puts the block in the basket. 5. Screener praises the child. Wonderful! That was a great job! Awesome! Next, to recondition or confirm that the child remembers the instructions and is ready for the screening, give the child a block and set the audiometer to 50 decibels and 4,000 hertz. Press the earphones on the patient, placing the red to the right ear with the diaphragm positioned directly over the ear canal. Ask the child to listen for the beep and then press the tone. If the child puts the block in the basket, you may start the screening of the right ear at 20 decibels and 4,000 hertz down to 500 hertz. If the patient does not put the block in the basket, switch to the left ear. If the patient still does not put the block in the basket, take earphones off and repeat conditioning and confirmation steps. If the child still does not cooperate, schedule a rescreen in 2 to 6 weeks. Traditional audiometric screenings are performed on children 7 years and older. Similar to play audiometry, the screener shall condition the child to orient them to the procedure. Position the child on your dominant side for screening. Turn on the audiometer, set the audiometer to the right ear and to pulse tone. While keeping the headphones on the table, set the audiometer to 90 decibels and 4,000 hertz. These settings will make the beep loud enough to hear without putting on the headphones. Present the beep sound to the patient to orient them on the sound they should expect to hear. Instruct the patient to listen and raise their hand when they hear the beep and lower it when it ends. Press tone for 1 Mississippi and acknowledge that the patient heard the sound when they raise their hand. The screener praises the patient with "Wonderful! Good job! Awesome!" Next, to confirm that the patient is ready for screening, set the audiometer to 50 decibels and 4,000 hertz. Put the earphones on the patient, placing the red to the right ear with the diaphragm positioned directly over the ear canal. Ask the patient to listen and then press the tone. If the patient raises their hand, you may start the screening of the right at 20 decibels and 4,000 hertz. If the patient does not raise their hand, switch to the left ear. If the patient still does not raise their hand, take the earphones off and repeat conditioning and confirmation steps. If patient still does not respond, schedule the patient for a rescreen in 2 to 6 weeks. After the child successfully completes the conditional and confirmation phases, they may now proceed to the screening phase. Set the audiometer at 20 decibels and 4,000 hertz if the child is under 11 years old, or 20 decibels at 8,000 hertz if the child is 11 years and older. Confirm the ear selector control knob is set to the right ear. Beginning with the right ear, press the button for 1 Mississippi until all frequencies are measured and the patient's responses are noted. It is important that the patient not see the examiner pressing the button so that they won't be pre-warned. Praise the patient every time they raise their hand. Now, switch the ear selector control knob to the left ear and repeat the process. This time starting at 500 hertz and progress to 4,000 hertz or to 6,000 and 8,000 hertz if the child is 11 years and older. Praise the patient each time they raise their hand. When the screening is complete, remove the earphones and thank the patient and document the results. Documentation of results. Complete documentation of audiometric screening results on an audiogram. Record a passing audiometric result with a check mark at the completion of the screening procedure. Immediately record a non-passing audiometric result with a dash mark while praising the child. Referral and follow-up. If the child does not pass the initial screening, rescreen in 2 to 6 weeks. If they do not pass the second screening, refer the child to a specialist. Refer any suspected hearing loss to a medical specialist. 2 failed screenings at least 6 weeks apart can be referred to California Children's Services, or CCS. Maintain a referral log to track status of the referral and follow up with the patient as needed. If the patient is uncooperative and you are unable to perform the test, chart appropriately in an audiogram, a screening form, or a progress note. Reschedule the screening within 2 to 6 weeks. Avoid superbilling the service until the screening is complete. Equipment care and maintenance. Headphones should be covered or cleaned before and after testing with alcohol wipes, with care taken to avoid moisture and exposure to the diaphragm. Use an accredited service vendor for an annual and routine inspection and calibration. Retain all documentation of calibration and repair. Notify a supervisor if any of the following issues occur, such as distorted or absent tone, dropped headphones or system, persistent static, unstable earphone fit, inoperative indicator light, frayed cords, torn earphone cushions, or a non-functional dial switch. Now that we've covered how to screen a child, let's discuss why it is important to routinely screen them, starting with how hearing loss affects the child. A child can be affected by hearing loss in the following ways: ability to communicate, isolation from family and friends, self-esteem issues, and/or academic performance. Research indicates that children under the age of 15, 60% of hearing loss could be caused by treatable infections such as meningitis, measles and mumps, and chronic ear infections. This is why it's important to have routine assessments throughout their childhood. To better understand different types of hearing disorders, we must first review the different parts of the ear: the outer ear, the middle ear, and the inner ear. Sound travels into these areas and is interpreted by the brain. A hearing disorder may be defined as a problem in these 3 areas, which is part of the hearing mechanism, which prevents it from functioning normally. Therefore, proper screening, referral, and follow-up are important to identify any hearing problems. Please refer to the links located at the bottom of the slide to learn more information on the anatomy and physiology of the ear. Common outer ear problems that can affect the outer ear include wax buildup, otitis externa or swimmer's ear, foreign objects such as food or toy, and lesions of the ear canal. Outer ear problems may include congenital atresia, as seen in this photo. Some identified problems of the middle ear may include otitis media, perforation of the eardrum that may occur with punctures by foreign objects, loud noises, fluid pressure buildup, otosclerosis, or malformation of the middle ear. Here is an example of a foreign body perforation. Listed here are problems involving the inner ear. Acoustic neuroma is a non-cancerous tumor that develops on the nerve that connects the ear to the brain. Benign paroxysmal positional vertigo causes mild to intense dizziness. Drug-induced ototoxicity may be caused by a certain class of antibiotics, such as aminoglycosides. Meniere's disease that affects balance and hearing due to abnormal fluid levels, purulent labyrinthitis, which is a bacterial infection that causes hearing loss and loss of vestibular function, and vestibular neuronitis, which is an infection of the vestibular nerve and affects balance. 3 types of hearing loss are conductive, sensorineural, or mixed. Please refer to the link located at the bottom of the slide to learn more about the 3 types of hearing loss. Conductive, caused by outer ear canal or middle ear structure abnormalities. It can also be caused by persistent otitis media with effusion. Sensorineural, caused by inner ear structural abnormalities. Causes can include family history, congenital infections, bacterial meningitis, ototoxic medications, and hyperbilirubinemia. Mixed is a combination of the above. Hearing loss affects the child. It affects the child's ability to communicate because it interferes with the development of language, learning, and speech. A child with severe hearing impairment has distorted speech that an average listener cannot understand. It may isolate the child from family and friends. A child with hearing impairment is deprived of usual opportunities to learn language, speech, social skills, and may develop a feeling of low self-worth. A child with hearing loss often demonstrates problems with adjustment. Some children compensate with their behavior by becoming overly aggressive or disobedient. Some children may withdraw, avoid, or shun group activities. Also, hearing loss can result in poor academic performance. And this is why early hearing screenings are necessary. Early detection of hearing loss at 4 to 6 years of age can avoid lifelong developmental deficits. Detection of hearing abnormalities ensures children have healthy cognitive and socioeconomic development, and they improve the well-being of the child and the entire family. Early discovery of hearing loss is the key to successful treatment. Audiometric screening post-test. 1. Conditioning means to A. Screen the child, B. Teach the child how the screening is done, or C. Remind the child how to play the game. B. Teach the child how the screening is done. 2. When conditioning the child, at what intensity, dB, and frequency, Hz, do you set the audiometer? A. 50 dB and 4000 Hz, B. 85 dB and 1000 Hz, C. 20 dB and 4000 Hz, or D. 90 dB and 4000 Hz. D. 90 dB and 4000 Hz. 3. When screening children 11 years and older, set the audiometer at 20 dB and test them on what frequency or frequencies? A. 500 Hz, B. 1000 to 4000 Hz, C. 6000 and 8000 Hz, or D. All of the above? D. All of the above. Four. When should you refer a child to a specialist? A. After 1 failed screening, B. After 2 failed screenings, or C. Never refer a child? B. After 2 failed screenings. 5. Which symbol indicates a failed screening when documenting results on an audiogram? A. A dash, B. A check mark, or C. A question mark? A. A dash. 6. True or false? Based on the Bright Futures periodicity schedule, hearing screening is only performed at 4, 5, 6 years of age, at 8 and 10 years, once between 11 and 14 years old, once between 15 to 17 years old, and once between 18 to 21 years old, indicated with a dot. A hearing risk assessment is done during the other ages, indicated with a star. A. True, B. False. A. True. 7. Blank should be used to clean the earphones. A. Alcohol-free wipes, B. Paper towel, or C. Alcohol wipes. C. Alcohol wipes. 8. On which of the following groups can play audiometry be used? A. Children 3 to 6 years of age, B, older children who appear to be shy, C, children with special needs or language challenges, or D, all of the above? D, all of the above. 9. Audiometers must be calibrated A, at least every 5 years, B, at least every 12 months, C, as needed when equipment is not functioning properly, or D, both B and C. D, both B and C. This concludes the audiometric screening training. Listed here are the references used to develop this module. Thank you for your participation. If you have any feedback, questions, or concerns, please contact your Medi-Cal Managed Care Health Plan.